Thank you so much. Welcome, everybody. I'm happy to share with you our frequently asked questions presentation in an attempt to help you get the lay of the land with all the different endocrine testing modalities that we offer, doctor's data. So let's start at the beginning. Why is it beneficial to test hormones and neurotransmitters together? The scientific answer is because hormones can impact synthesis, breakdown, and receptors, and vice versa. So I'm going to say that again. Scientific answer is that hormones can impact synthesis, breakdown, receptors, and action of neurotransmitters, and vice versa. Neurotransmitters can do the same for hormones. But the clinical reason is that oftentimes symptoms look the same, whether they're caused by neurotransmitters and or hormone imbalance. Testing is going to cast a wider net that enables you to locate the origin of the imbalance in order to narrow your treatment. Ideally, you would test them both together as a baseline to address the entirety of the neuroendocrine system. This image shows some potential interactions between hormones and neurotransmitters. As one example, on the right here, we're looking at hormones. Estrogen plays a role in hypothalamic temperature regulation, and it increases serotonin production and receptor activity. On the left here, we're looking at neurotransmitters and specifically serotonin, which promotes cortisol production, it stimulates ACTH, and it influences thyroid hormone. So with any symptom that a patient is going to present, you might question, is this hormone or is it neurotransmitter related? And the answer is often going to be both due to that symbiotic relationship that I was describing between hormones and neurotransmitters. And it can be hard to tell or guess without testing. So where should you begin with your testing? Anything that's related to mental emotional symptoms such as stress, anxiety, and depression, think neurotransmitters and always include cortisol. So that's what you're seeing here in these top two boxes. We're looking at mental health symptoms, behavioral symptoms, anything that's unrelated to hormones or cycling or changes of life. So in children, neurotransmitters and cortisol, and for mental health, neurotransmitters and cortisol. But anything that's sex hormone related, and such as low libidos in men and women, postmenopausal females with hot flashes and insomnia, cycling women who might be experiencing PMS, PMDD, irregular cycles, menorrhagia, or oligomenorrhea, you're definitely going to want to start with your hormones and your cortisol. And depending on the rest of your goals and your patient's budget, you may very likely add neurotransmitters on as well. For HPA axis retesting, cortisol levels are going to shift slowly after you begin your treatment, even when the symptoms are improving. So we recommend that you wait 6 months to a year before you're going to retest diurnal cortisol and saliva. When hydrocortisone is in the picture, we usually recommend retesting 3 months later with a 4 to 5 day washout period. And we're going to discuss that in greater detail later on in the presentation. With urinary hormones and metabolites, such as the HuMap, we recommend retesting 12 weeks after initiating treatment. For salivary sex hormones, we recommend testing 3 months after starting your bioidentical hormone replacement therapy and or after you make a dosage adjustment. When the dosing is stable, you're going to be retesting yearly, but sooner if there's a change in the symptom picture or if there's a dosage adjustment. With neurotransmitters, you're going to wait about 6 months after initial testing, as like cortisol, they take a while to shift with treatment, and sooner if indicated, or when there's a change in symptoms, or if there's a psychotropic medication change, or if there's a new one added in. How can you get help with your reports, interpreting them, and coming up with treatment suggestions? Well, you can call our fabulous staff doctors team at the number here anytime between 8:30 and 4:00 p.m. Pacific time, Monday through Friday. No appointment is necessary, so you can call us at your leisure. If you prefer to have an appointment, you can email us here at this email address, staffdocs@doctorsdata.com. Let us know the best phone number to reach you, a couple dates and times that work for you and your time zone, and we will email you back with a confirmation for an appointment. One thing that I want to point out is that each of us on the staff doctors team with whom you'll be consulting are all clinicians, and we all have our own practices. So we are using these tests in our practice every day. So let's talk specifically about urine hormone testing, or the HuMap. Urine metabolite testing gives you a window into how hormones are being metabolized and moved out of the body. It gives you a view into phase 1 and phase 2 estrogen detoxification. These ratios are also going to reflect enzyme activity, and it's going to allow you to see certain patterns of imbalance which are associated with higher risk of hormone-driven cancers. Which patients are going to benefit from HuMap testing? Definitely cycling females and postmenopausal females, males age 12 and over, and anybody dealing with the following conditions over here on the right. Specifically, if somebody has a personal or family history of a hormone-driven cancer, breast, uterine, or ovarian cancer, anytime somebody has endometriosis or PCOS, is a good reason to test with HuMap. Metabolic syndrome is a common reason to be testing. Insomnia, mood, cognitive concerns, the list goes on and on and on. So there's a lot of really good reasons to run HuMap in your patients. What are the differences between urine and saliva hormone testing? Well, there are a lot of differences. So that's why we've got a picture of apples and oranges here. Salivary hormone testing is going to measure mostly the biologically active or free hormones that are available to the tissues. And it's our favorite choice and our best choice for monitoring hormone supplementation, as it can reflect hormone dosing delivered by any route, so sublingual, vaginal, oral, topical, etc. Urine testing is going to reveal how hormones are being metabolized, detoxified, and eliminated from the body. These metabolite ratios are going to indicate how enzyme catalysts are performing, and it's going to show you which metabolites are biologically active. So many providers are going to elect to use urine metabolites to inform their bioidentical hormone supplementation. We don't necessarily recommending urine results to determine a starting point for BHRT supplementation, because urine metabolites don't necessarily represent tissue levels of active hormones. But if you see a pattern of low hormones on a urine test, we recommend refluxing to saliva to confirm that those levels are also in the tissues before considering BHRT. And I would say that one exception to this rule is with progesterone, because we know that women over the age of 37, their progesterone levels are going to drop precipitously. So you may just start with a HuMap with your patient. And if she's got a lot of progesterone insufficient symptoms, you may go ahead and put her on progesterone and then follow up with some saliva testing a couple months later to see if she's within the reference range. Using urine testing to adjust HRT dosing can be tricky. And by the way, I'm using HRT and BHRT interchangeably here. We used to use bioidentical hormone replacement therapy, BHRT, but now there's so much more conventional treatment that's also using bioidentical hormone replacement therapy. So whether I say BHRT or HRT, I'm really referring to any of that bioidentical estrogen, testosterone, and progesterone, as well as hydrocortisone that's available. So using urine to adjust your hormone supplementation can be tricky, and it's not our first choice because of the physiology of hormone absorption, transport, and metabolism. So, for example, transdermal application is going to deliver HRT to the capillary beds underneath the skin, where it travels via red blood cells directly to tissues, where it can be measured in saliva. Whereas blood and urine levels are only going to increase if transdermal dosages exceed the carrying capacity of the red blood cells. So urine tends to underestimate transdermal hormones. Orally delivered HRT will go through first-pass metabolism in the liver, which leads to higher metabolites. So urine overestimates oral doses of hormones. So will using the HuMap help with dietary and supplementation considerations? Yes, it's a great starting point for determining nutrient, herbal, and lifestyle recommendations to help support the enzymes of all of these different detoxification pathways. It can also reveal patterns of metabolism that are related to health conditions such as hypo or hyperthyroidism, insulin resistance, and inflammation. In the next couple of slides, I'm going to show you how the treatment guide can give you some suggestions for dietary and nutritional support. Here, we're going to focus on the estrogen neighborhood over here on the right. This is a 68-year-old male on testosterone. And you can see in the estrogen neighborhood that he's aromatizing to estradiol and estrone from testosterone and androstenedione. I want to draw your attention to these red circles on the right, specifically how they relate to the treatment guide. So while the entire estrogen neighborhood is hot with aromatization, we're just looking right here at this phase 2 detoxification via methylation, and specifically at the 2-OH and 4-OH pathways where methylation takes place via the COMT enzyme. I also want to point out that this 4-methoxy-E2 is going to show up at gray on your reports for now because there's a worldwide shortage of the enzyme that helps to measure the 4-methoxy-E2. So for a while, you'll see that as gray, but as soon as we have access to that enzyme again in our lab and in all labs, you're going to be seeing that analyte show up again. On the left, you see the therapeutic considerations guide, or also called the treatment guide, which is located on the website. And on the right, you see a glimpse into how this treatment guide is laid out. So on the prior page, we saw that the need for support for phase 2 detoxification for the patient. And here you see some specific research-based suggestions on how to support that COMT enzyme using foods, spices, and nutrients. And so that's what you're looking at right here. So what's unique about the HuMap versus other urine tests from other labs? Well, because the HuMap is done from a wet liquid urine versus a dried urine collection, there's no need for reconstitution in the lab, which enables creatinine to be measured directly. On page 1 here, we're looking at an overview of the most clinically relevant information that's offered by the HuMap. So as mentioned, we're looking at methylation and phase 1 and phase 2 detoxification here, metabolism of estrogens, the gray bars, 5-alpha reductase activity, and you're looking at this graph of diurnal cortisol and cortisone. The HuMap testing also includes progesterone, allopregnanolone, and androstenedione, which are analytes that aren't offered on all urine metabolite panels. It reports 2-methoxy-E1 and E2 as well as 4-methoxy-E1 and E2 metabolites. It shows up as individual color-coded pathways. It's convenient to collect urine samples and freeze and ship them. And you can always add on neurotransmitters using the same sample. So I'm showing you right here how we do our color coding because this can be confusing for some people. So in the middle here, the light blue, the green, and the yellow is within range. Light blue being low range, green being the middle of the range or the functional zone, yellow being upper range, red is abundant or high, and the darker blue is low. And so when you look at your patient's pathway diagram on page 2, it's a heat map, so it's reflecting those individualized results. You can see where the hormones and the metabolites are coming from and when they're going and which enzymes are involved. So now let's talk about some common questions regarding collecting urine for the HuMap. I'm just going to point out here that you're only going to receive 1 collection cup in your kit as opposed to 5, as it says here. So you just use the 1 and then you rinse it out and reuse it for each collection. Does your patient have to stop taking hormones prior to collection? Well, it depends on the route of delivery as there are different dosage intervals for each one. So note that because of the different ways that hormones are metabolized, depending on the route of delivery, the dosage interval is going to be slightly different for urine than it is for saliva. So for topical and injection, subcutaneous pellets and transdermal patches, you're going to continue hormones based on your regular schedule. But if you're doing any vaginal application, you need to discontinue for 72 hours to prevent any contamination of the urine. For sublingual and oral, you're going to continue for 72 hours prior and during sample collection. And for cortisol and hydrocortisone, the same as saliva, you're going to discontinue for 4 to 5 days prior to sample collection so that you can, your results will reflect endogenous production. For a night shift worker, collection times should correspond to that patient's pattern of eating and sleeping on a workday. The same goes for their saliva collections. So that dinner time collection is done approximately 4 to 7 hours before they go to bed, or their longest sleep for the day, whenever that is, or before they eat their last meal for the day. The bedtime sample is collected before the longest stretch of sleep for the day. The waking collection is done after they wake up from that longest stretch, even if it's in the middle of the night or late in the afternoon. And the post-waking sample takes place 2 to 3 hours after that waking collection. If the patient can't wait and has to void before the collection time, they can go ahead and collect that sample early. But just impress upon your patients that it's best to collect from as full a bladder as possible, and when there's been at least 2 hours since the last urination for best results. If a patient can't collect at the requested time, they should hydrate and collect as soon as they are able. Urine samples should be frozen for at least 4 to 6 hours prior to shipping. So that means that if one collects their last sample at 10 in the morning and they put it in the freezer, they can call FedEx for pickup between 2 and 4 p.m. and they can get it sent off in the same day. It's also fine if they freeze samples overnight. So speaking of urine, in the next section, I'm going to answer the most common neurotransmitter questions, because neurotransmitter testing is also done through urine collections. Does this testing measure brain levels of neurotransmitters? Well, it's a common misunderstanding that neurotransmitters are only secreted and received in the brain. Let's pause and take a quick review here. Neurotransmitters are the chemical messengers of the autonomic nervous system throughout the entirety of the body. They transmit messages between neurons or from neurons to muscles. They are secreted in both the central and the peripheral nervous systems, and they're catalyzed by the same enzymes both in the brain and in the periphery. So while we can't measure what's in the synapse, the urine testing is going to reflect whole body production, and it correlates well with symptoms. So for example, we know that serotonin can influence mood. Yet 80 to 90% of serotonin is secreted in the GI tract, having a direct impact on that tissue. Epinephrine and norepinephrine are secreted in the periphery as part of the stress response to impact muscles and cardiac function. And dopamine receptors have been located in coronary, renal, and cerebral tissues. Glutamate receptors have been located in the heart, kidney, lungs, and endocrine glands. So you can see how a whole body collection in urine is going to reflect the entirety of the nervous system. What patterns can you expect to see in depression and anxiety? Well, there are no set patterns because everybody's brain and body chemistry is slightly different. Low and high levels can manifest in similar symptomology. So just because someone's using an SSRI or an SNRI, it doesn't necessarily lead to within range or upper range serotonin and norepinephrine levels. And it may not even mitigate the symptoms for which they're prescribed. So what we recommend is just testing and addressing deficiencies and elevations where they fall and just meeting the patient where they're at. So this is a patient of mine, a 15-year-old female who is on both an SSRI and a birth control and on oral birth control. She came to me already on the SSRI, so unfortunately I wasn't able to get a baseline on her. But what's interesting to point out here is that her serotonin levels are just barely within the functional range. They're just sort of teetering on low range. And just to show you an example of how you might think an SSRI is going to elevate those serotonin levels, but not necessarily. So usually when serotonin levels and dopamine levels are a little bit higher within that functional zone, that green zone, people feel better. So that's something to consider. One big concern that providers have is serotonin syndrome if they're supporting that serotonin pathway, specifically with 5-HTP. So it's nice to test these folks to see that in this case, for example, she could use some 5-HTP and there's really no concern about serotonin syndrome. In terms of the entirety of these results, I also want to point out that this person's histamine levels are low, which we'll often see in diets that are lacking in protein. And she also had low PEA levels, which correlates with some of her ADD, ADHD symptoms. And this is pretty common to see low PEA levels in that population, folks who are on that ADD, ADHD spectrum. And here you can see the neurotransmitter pathway chart. And in red are all the nutrient cofactors that are going to support those enzymes for conversion and transmission. And we're going to talk about this again a little bit more, but specifically that birth control pill that my patient is on is going to be depleting magnesium, B vitamins, vitamin C, and zinc. And those are all required for neurotransmission. So anytime a patient is on an oral birth control, I'm going to make sure that they're on a multivitamin to make sure that all of those nutrient cofactors are in place. So here's how you can access some of our treatment guides. If you go up to the News and Knowledge and hover your mouse and click on Materials and Resources and go over to Endocrinology Resources, at the top of the page is Hormones, and at the bottom of the page is Neurotransmitters. So at the very bottom of that page under Neurotransmitters is our Neurotransmitter Support Supplementation Consideration Guide. And the very top is serotonin. Now, specifically for that patient, she wasn't low, but you can see what some of the suggestions might be to help to support that pathway. There's the 5-HTP that we discussed. Rhodiola is a great option there. L-theanine is a nice way to modulate high and low levels in neurotransmitter results. And then, of course, all the nutrient cofactors that we've been talking about. So should you run the NeuroBasic profile or should you run the comprehensive neurotransmitter profile? Well, the difference between the two is that the basic profile is going to show you the neurotransmitters that are in purple outside of these green circled areas. And within the green circled areas, you're seeing what's included in the comprehensive neurotransmitter profile. Specifically, these are the metabolites of the neurotransmitters, as well as taurine. And so sometimes it just comes down to the patient's budget, whether I'm going to order the basic as I did with the NeuroBasic as I did with my patient, or if you're going to add in the metabolites, which is going to give you some more information about enzyme activity. And as mentioned here, we're looking at the conversion of norepinephrine to epinephrine, and you can see that norepinephrine is converted to normetanephrine via the enzyme COMT, and as well epinephrine is converted into metanephrine via COMT. So you'll be able to look at normetanephrine and metanephrine on that comprehensive neurotransmitter profile. So how long should your patient supplement before retesting? Well, we recommend waiting at least 6 months before retesting, because as we mentioned earlier, neurotransmitters are going to take a while to adjust to treatment. And we often find that patients are going to feel better before we start to see changes in their actual results. Can you test patients who are using psychotropic drugs? Yes. And we recommend that you keep your patients on psychotropic drugs because we want to see how those drugs are impacting your patient's biochemistry. Especially if they've been on them for a while, we prefer that they stay on them so you can see how it's impacting their chemistry. Keep in mind that we'll often see low and low range levels in these patients in both serotonin and norepinephrine when they're using SSRIs and SNRIs. And there's research that reflects that long-term use leads to long-term use of SSRIs is going to lead to depleted serotonin levels over time. For patients who are discontinuing medications, how long after they're stopping the psychotropic drugs will you see baseline or endogenous levels? Well, it really depends on the drug in question. It takes about 5 half-lives for 95% of the medication to be eliminated, which is an average of 6 to 8 weeks for most medications. The half-lives of some of the most common medications vary from 4 hours to 6 days. So I want to emphasize that it's not advisable to discontinue psychotropic medications. We know that stopping suddenly can cause withdrawal symptoms, as well as return of the symptoms being treated. So we really don't recommend that you take your patients off for evaluating their neurotransmitter levels. This information is really more for patients that are already in the process of discontinuing their medications. Can patients take amino acids while they're using their psychotropic drugs? Yes, but we don't recommend supplementing amino acids on top of these psychotropic medications unless you first check their neurotransmitter levels, which can help to avoid causing elevations. If a patient is on an SSRI and it helps their depression, but not enough, the testing could reveal, as with my patient, low range serotonin, and you can feel comfortable adding in some 5-HTP without concern about raising serotonin levels too high. What drugs can have a negative effect on neurotransmitter levels? Well, it's important to understand that many medications are going to deplete the cofactors necessary for neurotransmission. So up here in the orange box, we're looking at H2 blockers, protein pump inhibitors, and antacids that are going to deplete folate, B12, vitamin C, calcium, iron, and magnesium. Antibiotics, metformin, and anti-inflammatories are going to impact folate, and oral birth control pills are going to deplete folate, magnesium, B6, B12, vitamin C, zinc, and selenium, all so important for that neurotransmitter production and transmission. This is a chart of more common medications that are going to increase or decrease neurotransmitter levels themselves or affect their receptors. It's a great resource that was created by our colleague, Dr. Heidsieck. Just because a medication is supposed to increase a neurotransmitter, it doesn't mean that it will, but it may be higher than prior to starting the drug. And so, yes, that's another reason to test first. So you can take a look at this later when you get the slides from the presentation. So how does cannabis impact neurotransmitter results? Well, THC and CBD are the two main phytocannabinoids in cannabis. THC has been shown to transiently elevate dopamine, but long-term use has been shown to lower levels of dopamine and glutamate. It's also a partial agonist of the CB1 receptor, which mediates the release and reuptake of norepinephrine, dopamine, 5-HTP, GABA, and glutamate. CBD has been shown to increase serotonin and activate glycine receptors. Note that the half-life of THC is 20 to 30 hours, so approximately one full day. So if you're trying to evaluate your patient's endogenous levels in a recreational or chronic user, we suggest waiting at least 150 hours, so to be on the safe side, 1 to 2 weeks. Creatinine is not diagnostic. It's utilized as an indicator of urine concentration when we calculate neurotransmitter levels. It has no diagnostic value, and it's not an indicator of renal function. Lower levels can indicate more dilute urine, whereas higher levels are a result of more concentrated urine. So if samples are too dilute, the lab is going to discard them, and the provider is going to be notified. So results will not be run on too dilute or too concentrated samples. What's important to know about sample collection for neurotransmitters? And how are you going to decide between a 24-hour versus a spot urine collection? The 24-hour is going to allow you to measure the average excretion over a day, and it's reflective of the influences of foods and stressors. This is the only option for patients with kidney disease. Compliance can be difficult, and even one missed void can really skew results. The spot testing, meaning the first or second morning void, is going to allow you to measure baseline neurotransmitter levels with less influence from environmental stressors and foods, and it correlates well with those 24-hour results. It's the more convenient and popular option, and it saves your patient from having to carry the dreaded orange bucket around with them all day. The second void was the industry standard for a long time. It's still used by many providers, but recent studies have shown that the first void is just as reliable, if not more so, in capturing baseline levels free of outside influences such as foods and stressors. The second void can be difficult to have to wait until after that collection is taken in order to eat, drink, exercise, and start their day. So generally, we recommend that first morning void. Why do patients need to avoid bananas and certain foods prior to during their neurotransmitter testing? Well, these foods contain tryptophan and phytomelatonins, which can contribute to increased serotonin levels. Alcohol, nicotine, caffeine, and tyrosine-rich foods can contribute to increased dopa, norepinephrine, and epinephrine. Strenuous exercise the day before testing can also contribute to higher catecholamine levels. So it's recommended to avoid these foods for 48 hours before testing, and also these substances and rigorous exercise for 24 hours prior to testing. What if your patient can't or won't do the food and substance avoidance? Is it still okay for them to collect? Just keep in mind that the test will reflect levels most accurately if the avoidance has been completed properly. Consuming these items is going to bring some ambiguity into the results, making interpretation a little bit more difficult for you. So you could help your patient by providing them with a 2-day meal plan and or a diet diary. You could also consider in these folks the second morning void to minimize the effects of these foods. For patients who can't uphold a 24-hour withdrawal from nicotine, make sure that that first AM collection is done before their morning nicotine use, and make sure that there's no waking in the middle of the night to use nicotine before collecting in the morning. So now on to the cortisol awakening response. The cortisol awakening response is that natural rise in cortisol that takes place approximately 30 minutes after waking, and it's followed by a noticeable drop 60 minutes after waking. The clinical value that it adds to results is that it can provide information about overall HPA-active responsiveness and function that may not be revealed by the diurnal cortisol profile. So in this example, the AM60 should be less than or equal to the waking value, but instead it's very high. So a result like this can provide additional treatment considerations that can help you and your patient manage their morning anticipatory stress. So here we're looking at the cortisol profile with the 4 points in time. And here we're looking at a diurnal cortisol profile with the cortisol awakening response added on. So these 2 additional vials at waking and for AM60. And you can add those 2 additional vials onto any saliva samples, or you can order it as a standalone test of just 3 tubes to measure the waking, the AM30, and the AM60. I will often run the cortisol awakening response as a follow-up to a diurnal cortisol report when the AM is low, but the levels later in the day are within normal limits. So such as this. So if I have a patient who's got, a pretty low morning level like that, but then they return to optimal functioning for the rest of the day, I'm curious if they have either a very early cortisol awakening response or if they have a very late cortisol awakening response. So I'm usually going to add that into their testing within a couple months of doing that initial testing. This is a list of symptoms and conditions which can be associated with an abnormal cortisol awakening response. So think about any condition that involves stress upon waking or trouble waking up and getting out of bed, or fatigue, depression, any lack of sunlight or full spectrum light are all going to play a role and make somebody a good candidate for the cortisol awakening response testing. So how do you interpret the cortisol awakening response? In this example, the comments down below here say that the patient's CAR rise is less than expected and the patient's CAR decline is greater than expected. So this can get confusing. Let's break this down a little bit more. So ideally, 30 minutes after waking, the cortisol should be 35 to 60% higher than it was when the person first opened their eyes for the day. This is the rise, and I apologize. We added this back in, and I think I grabbed the wrong. I forgot to refresh my report, but you should have this in your PDF slides. So this is showing you the dotted line at the waking value, and then another dotted line to show you where the rise should be. And when the rise is less than expected, it means that the cortisol didn't rise enough or it dropped. And that's what you're seeing here. On the right, you're looking at the decline 60 minutes after waking, when the cortisol levels should recover back to the waking value. Think of this as a noun, not a verb. It makes it a little less confusing. So on the left, the patient's CAR rise is less than expected, meaning it should have gone up when it went down. And on the right, the patient's decline is greater than expected, meaning that it went up when it should have gone down. And so this came from these results from the prior page. So this is what you were looking at on the left, and this is what you were looking at on the right. What if your patient wakes in the middle of the night and then goes back to bed and sleeps until morning? When should you collect the cortisol awakening response? Well, the whole point is that you're going to be collecting on a morning that is typical for that patient. So if the patient wakes up every night to go to the bathroom, they go back to bed, they wake up at 7 a.m. That's typical. It's totally fine to collect on that day. But if that is atypical for your patient, you want to wait until a morning after they have had a typical night of sleep. So in this section, we'll discuss diurnal cortisol testing and treatment. So what is the significance of adrenal phasing? It's a way to categorize the degree of HPA axis dysfunction, and it can help to guide your treatment approach. So because morning cortisol is reflective of overall HPA axis responsiveness and adaptation, phasing is based on that AM 30. Upper range or high cortisol at any point is going to be considered phase 1. It can also indicate a zigzag pattern where you see elevations throughout the day. An evolving HPA axis dysfunction is going to be reflected in a phase 2 pattern, such as here, and a phase 3 is going to reflect a longer-term HPA axis adaptation to more chronic stress. So, and this is what you might see over time too, this elevation leading to a lower or flatter morning cortisol level, and then over time leading to a flatter and lower cortisol awakening response, that AM 30. This chart spells out what I was just explaining, and you can find this on the website, the different stages. When assessing the HPA axis, when should you run the HuMap and when should you run saliva? Well, keep in mind that cortisol has 2 functions. It has the proactive function of providing a diurnal rhythm to instigate waking up and preparing for the day. It also has a reactive function where it's releasing cortisol as part of the stress response to adapt to perceived stressors throughout the day. Saliva is reflective of individual points in time, and that's the diurnal rhythm, whereas urine is going to better reflect the reactive cortisol spikes since the last void. Or the overall cortisol load. So an example of that, these are samples from one patient that are taken in the same 24-hour period. If you only looked at the saliva graph on the left, you might think that this patient needed hydrocortisone supplementation as she is nearly flatlined in her diurnal cortisol saliva spot collection. Yet her urine results on the right paint a very different picture, reflecting her cortisol load since the last void. So in this case, the patient has elevated levels when she wakes up in the morning, reflective of spikes in cortisol overnight. So when we see this, we're wondering about sleep hygiene, insufficient darkness, sleep interruption, frequent wakings. And this is all fodder for some good conversations with your patient to talk about what was going on the night before they collected their samples. And her overall cortisol load reflects a more active cortisol metabolite versus cortisone. Cortisol is active, cortisone is inactive. And when we see this preference for the more active cortisol, we're thinking about hypothyroidism, we're thinking about blood sugar imbalance and inflammation. And if you'd like to learn a little bit more about this, I recently wrote a newsletter article on the website entitled Comparing Cortisol Testing in Saliva and Urine, where we do a deeper dive into when you might choose saliva and when you might choose urine to evaluate cortisol levels. And these are some suggestions on how to tailor your treatment based on HPA axis phasing, which can lead to lifestyle optimization, vitamins, adaptogenic herbs, adrenal glandulars. And I will say that the research does show that the lifestyle modifications, rest, meditation, breathing are the things that are going to have the most potent impact on and moving those cortisol levels back into the more optimal zone. Hydrocortisone supplementation is usually reserved for phase 3 cases. It has a very short half-life of 1.5 hours, so it's not likely to suppress the HPA axis at low doses. The adrenal glands are going to produce about 20 milligrams of cortisol in a 24-hour period, so it's important when supplementing to avoid exceeding that. Depending on the level of severity of HPA axis dysfunction, providers will often start really low at a 2.5 milligram dose and work up as needed. We recommend that you start with a 3-month round of supplementation and then stop the patient for 4 to 5 days to retest so that you can evaluate their endogenous production. It also gives you a chance to see how well the patient is doing when they're off the supplementation. Do their symptoms return or do their symptoms get worse? And then you can just continue. If their symptoms are worse, it seems that you need to stay on the hydrocortisone. We recommend continuing to supplement and retesting in 3-month increments. So let's talk about reproductive hormones. Why is the supplementation range higher than the reference interval? Well, our supplementation ranges are based on the work of Dr. John Lee, and they reflect levels of a healthy, youthful endocrine gland. Dr. Lee tracked his patient response to treatment and found that it was within these ranges when people felt the best and when their symptoms and their bone density improved. And his data has been validated by our database of over 180,000 processed saliva kits. Metabolic syndrome affects androgens very differently in men and women. In men, insulin resistance is associated with low androgens, whereas in women, it's associated with high androgens. So let's break that down a little bit more. So here we're looking at how metabolic syndrome affects androgens in men. On the right, we're going to follow the blue arrows, and you're going to see that adipose tissue is going to contribute to aromatization, which is going to increase estrogen, which leads to an increase in sex hormone binding globulin, and that's going to lead to lower testosterone levels in men. On the left, we're looking at how adipose tissue is going to contribute to increased insulin resistance, which is going to lead to lower levels of LH, and that's also going to contribute to lower testosterone levels. We've got the opposite situation with sex hormone binding globulin in women. So in men, adipose tissue and hyperinsulinemia is going to increase sex hormone binding globulin. In women, it's going to decrease it. So this complicated image is showing you just that. So on the left, you're seeing hyperinsulinemia here in turquoise, and how it leads to low sex hormone binding globulins in women, which enables androgens to elevate, leading to hirsutism, menstrual irregularities, and reduced fertility. And that hyperandrogenemia is also going to contribute to insulin resistance. If you're planning to prescribe hormones, it's crucial that you're understanding the difference between progesterone and progestins. So here you're seeing bioidentical progesterone on the left and a progestin on the right. Bioidentical progesterone shares the molecular structure with what's produced endogenously in the human body. Progestins have a different molecular structure, leading to different physiological effects. Progestogens is an umbrella term that means hormones that affect progesterone receptors. Both progesterone and progestins affect progesterone receptors, but they have different effects. So on the left, we're looking at progesterone, again, bioidentical. Bioidentical progesterone can be safely supplemented during pregnancy to prevent miscarriage, whereas progestins are typically used to prevent pregnancy. And some progestins may even cause birth defects if used during pregnancy. Bioidentical progesterone is available over the counter through a compounding pharmacy or as a pharmaceutical product like Prometrium. Progestins are in HRT and birth control. Research has shown that natural progesterone is protective and preventive of breast cancer, and it may also be helpful in preventing cardiovascular disease and stroke, whereas progestins may contribute to breast cancer, coronary heart disease, strokes, and pulmonary embolism and dementia. How to use bioidentical progesterone? Well, we base our dosing on body weight. So under 150 pounds, you're shooting for a 20 to 30 milligram dose. 150 pounds or over, you're shooting for more of a 50 milligram or higher dose. The timing is going to be different depending on the age and the goals of the patient. If the patient is premenopausal and they want to conceive, you only want to dose them with progesterone during that second half of the cycle after they've ovulated to prevent suppression of ovulation. So if someone's using an ovulation tracker, that's going to give you a really good indication of when they can use progesterone without interfering with ovulation. If one doesn't have an interest in conception and they're still cycling, they can collect on days 7 to 28 of the cycle. In postmenopausal women, They can use progesterone every day. Just remember to start low and go slow with everyone that you're putting on progesterone, as there could be bloating or weight gain associated if you give them their goal doses right off the bat. So I usually start my patients at about 5 to 10 milligrams topically, and then I work up as needed and monitoring their symptoms along the way and letting them know that weight gain and bloating are possibilities if they increase their dosages too quickly. Hormone testing while on oral contraceptives can show you how the pill is affecting hormone balance, but we find that it tends to be quite predictable because of how it suppresses ovulation. And this, of course, is going to lead to progesterone insufficiency and potentially low-range estradiol and suboptimal testosterone. Progestins can't be measured by our laboratory systems, so the results are going to reflect that suppressed production of progesterone. So expect progesterone levels to be quite low in somebody who is on oral birth control pills. If one is on the IUD, it's a different story because it's a different mechanism. An IUD, like the Mirena, is going to thicken cervical mucus and it inhibits in sperm movement and viability. So you may see normal to low range estradiol and progesterone in a patient who is using a hormonal IUD. So it is nice to test to see where they land. Can you supplement progesterone in patients on oral birth control pills with progesterone insufficiency? Well, there's competition between that progestin in the oral, birth control pill and the topical progesterone at the receptor level, and it can negate the breast, brain, and cardiovascular benefits of that progesterone supplementation. Additionally, it's just not known if that progesterone supplementation can influence the effectiveness of oral contraception, hormonal contraception. Now, having said that, there are a lot of providers who do give topical or oral progesterone to women who are on the birth control pill or who are using oral contraceptives or the Mirena. And most of them say that they have had good results, but we just don't have the research to stand behind that. So it's something that you can discuss and with your patient, and perhaps they can use a barrier method during the times of month when they may be the most fertile, especially when they're on the IUD, when they still might be producing some progesterone and estrogen. What about dosing of progesterone for men? Well, progesterone is not just for women. Men are going to produce it in the adrenals, the testes, and the brain, and it's going to impact brain, bone, prostate, and sperm health. You might want to give a man progesterone when they have prostate symptoms, such as decreased urinary flow or benign prostatic hyperplasia, because of its ability to inhibit the proliferative effects that estrogen is going to have on those prostate cells. It's often combined with testosterone therapy in men to inhibit 5-alpha reductase to prevent the conversion to DHT. And it's often dosed with chrysin, a bioflavonoid, which is a natural aromatase inhibitor. A typical dose for men is about 5 to 15 milligrams per day. So what's the difference between the three estrogens, and when should you consider ordering all three in saliva? Well, estradiol, or E2, is the strongest of the three estrogens. It's usually what we're referring to when we use the term estrogen. Estrone is the predominant, or E1 is the predominant estrogen after menopause. It's produced in the ovaries, the adrenals, and adipose tissue. It is a metabolite of estrogen, of estradiol, and high levels may be associated with breast and endometrial cancer risk. Low levels may be associated with osteoporosis and vasomotor symptoms. Estriol is the weakest of the three and the most protective estrogen. It's elevated during pregnancy. It binds weakly to estrogen receptors, and it is considered protective against the proliferative effects of other estrogens. Testing all three gives you a calculation for the estrogen quotient, or the EQ, which was developed by Dr. Henry Lemon after studying estrogen levels in relation to breast cancer risk. The EQ is relevant for women over the age of 45, anyone with a personal or family history of breast, uterine, or ovarian cancer, in any kind of prevention-focused practice. And it's typically not indicated for men because we don't have a reference range for the EQ in men. Both the EQ and the PGE2 ratio are clinical ratios that will help to approximate risk of proliferative issues. and to help you target supplementation to minimize those risks. The EQ has a reference range for women only, while the PGE2 is relevant to men and women. Sufficient quantities of estriol, as indicated by an EQ of greater than 1 or an optimal of greater than 1.5, can help antagonize the proliferative effects of estrone and estradiol. The PGE2 ratio provides information to help address progesterone insufficiency symptoms and to protect breast, heart, and bones in women, and for minimizing prostate risk in men. The PGE2 ratio was developed by Dr. John Lee to help quantify progesterone insufficiency relative to estrogen dominance. In men, within range values are associated with lower risk of prostate symptoms and cancer. In women, within range values reflect breast, uterine, heart, and bone protection and are associated with relief from progesterone insufficiency symptoms. So let's talk about melatonin, which can also be measured in saliva. What if your patient has trouble falling asleep, but melatonin is high at night? So the most common reason for a pattern like this, where melatonin is very high in the morning and it's low range in the evening and then high again at bedtime, is usually supplementation with melatonin or 5-HTP or even an SSRI or an SNRI because of how melatonin and serotonin are on the same pathway. Serotonin converts into melatonin. Also, consuming foods that contain tryptophan or phytomelatonin could also play a role. I saw this pattern the other day when I was on the phone with a provider, and what we finally concluded is that this morning level was actually 4:15 in the morning. And when we looked at the collection times, and the provider wasn't sure if that was a normal wake-up time for the patient. We're assuming that it's not, just based on how high these levels are, these melatonin levels are. This could also be caused by having used melatonin the night before or 5-HTP. So don't ever assume that your patient listened to instructions and they didn't take their supplements as directed. They may have taken them, they may have forgotten. So that could be the reason for that level in the morning. And then in this particular patient, the levels were high at night because she went to bed very, very late at night, which also isn't usual for her. She usually goes to bed earlier. So this was a very atypical pattern for her. So it would make sense that her levels would be very high at night because normally she would be asleep. And we didn't know in this patient if she also may have used some 5-HTP or melatonin to help her sleep before she collected that last sample of the day. Elevated melatonin levels can be addressed with morning exposure to sunlight or a full spectrum light box if one doesn't have access to the outdoors. More time outside during the day in general, even in gray or rainy weather, because natural light is more suppressive to melatonin levels than artificial light. It's also going to help to promote those cortisol levels. And also consider neurotransmitter testing to rule out elevated serotonin, because serotonin can convert to melatonin. What about the question of safety of melatonin for children? Well, it really comes down to two issues. One, side effects, and two, the question of whether or not it can affect the timing of puberty. So the research on melatonin in the general population of children is lacking, but we do have quite a number of studies involving neurodivergent children with autism, on the autism or ADHD spectrum, which has shown us that melatonin has been beneficial and safe for chronic sleep issues, also for behavior and mood with little to no side effects. So the kinds of side effects that you might see in a child are the same as what you might see in adults, such as maybe some grogginess or sleepiness in the morning, maybe a low-grade headache. The concern that melatonin may affect timing of puberty comes from the fact that melatonin levels decrease precipitously just as or before children begin their stages of puberty. So it's thought that this drop in melatonin may play a role in the onset of puberty. So this is showing you melatonin across the lifespan, and you see this little dip in melatonin that takes place right after the lifetime peak of melatonin, which takes place in childhood right around the age of 10. So that dip precedes puberty. There was a paper that was just published in 2023. It was a small study of 50 boys aged 14 to 18, and it found that higher serum melatonin levels in boys with a constitutional delay of puberty correlated with lower levels of testosterone and FSH. So the researchers hypothesized that supplementing could interfere with the triggering of important pubertal developmental steps. The jury is still out on this. So in my patients, I usually try to avoid melatonin supplementation right around puberty, or sometime around the age of 10 or after. I tend to not go for melatonin right away with my young patients, preferring to support them with cognitive behavioral therapy or other kinds of ways to induce sleep, like taking a hot bath before bed or working on their bedtime routines. I will use melatonin as needed, but just wanting to point out this potential issue with puberty. And here's you can just take a look at these research studies if you would like to learn a little bit more about melatonin in children. So just a few more questions related to saliva collection practices. How long does one need to wait after their last dose of hormones before they start collecting their saliva? Well, patients on hormones need to follow the proper dosage intervals, and note that it's going to be different from the HuMap. Saliva dosage intervals are going to be different from the HuMap. So in saliva, using topical hormones, the last dose should be 12 to 24 hours before sample collection begins. With sublingual hormones or troches, there should be a 24 to 36 hour interval between the last use and when they begin their sample collection to try to rule out any kind of contamination. With oral hormones, they can continue as normal the day of collection or the night before. We just recommend that they collect that morning saliva sample before they take if they take their oral hormones in the morning, that they take them after they collect that morning sample collection. And if someone's using injections or pellets or transdermal patches, you want to collect halfway between dosages. So with the, let's say someone's using the Vivel estrogen patch and they replace it twice a week, you want them to be collecting between, 24 and 48 hours after they have replaced their dosage and their patch. And with subcutaneous pellets, if somebody replaces them every 3 months, then they're going to want to be collecting at about that 1.5 month mark. And to figure out if your patients properly time their hormone dosing, you can always look at the questionnaire that they fill out when they submit their samples. So in this case, the patient is on estrogen and it's a topical patch. And you can look down here to see that it was that 37 to 72 hours after she applied her patch before she collected, which is a little bit too long of an interval. We prefer to see the 25 to 36 hour interval range. So this may show up as lower levels of estrogen in results. With the estradiol, the patient's using a topical cream. Unfortunately, she applied the cream less than 12 hours before collecting. So this could reflect some elevations. And then with the oral dose, it was just fine at less than 12 hours because we're not concerned about that impacting because of that first pass metabolism in the liver. So this is the last question. With irregular cycles, when should your patient test salivary or urinary hormones? So when one has a very typical 28-day cycle, they're going to be collecting right around day 21, give or take 2 days, to try to catch that post-ovulatory progesterone surge. If somebody has a longer cycle, more than 28 days, you're going to count back 7 to 9 days before they usually the end or the beginning of their period, the end of their cycle or the beginning of their period. If one has ovulation pains, then that's a nice indication that they can collect about 7 days later because you know that they have been ovulating. For short cycles that are less than 14 days, collect around day 7 to 9. For an unpredictable or infrequent cycle, one can collect after day 14 and before day 1 of the next cycle. And in these cases, you may want to freeze the sample for 2 nights to ensure that their period doesn't start. And this is the sort of thing that we're thinking about with somebody with PCOS or a perimenopausal woman with unpredictable schedules. And if somebody doesn't really have a reference point, same as before, collect that sample and freeze it for 2 nights. And if after 2 nights they haven't started their period or begun to bleed, then they can go ahead and send it in. So that's the end of the presentation. Thank you so much for your time and attention. And I'll hand it back over to Angie.